Good afternoon and welcome to our first quality webinar of the year. We're glad you're able to make it today. We have a great session where we're going to be discussing OPPS and CPT and what you need to know to have a successful start to your 2026. We have great presenters today, so if you are interested in learning more about them, you can do that in the Meet the Speaker section of this On24 platform. Again, we have a great session today with a lot of content, so we are actually going until 2:30 today. We are recording today's session that you'll be able to access on our website in the next couple of weeks. We are utilizing the On24 platform, which is a web-based platform. There is no dial-in number, so if you are experiencing any audio issues, check your speaker settings as well as doing a quick refresh on your browser, and that should fix any of the glitches. We do have a media section, and if you do need closed captioning, we do have that available for you. We do encourage you to ask questions throughout, and you can do that in the Q&A section, and we'll get to as many questions as we can at the end. Also take a look at the resources section. In that, we do have today's presentation for download. We also have our certificate of attendance. We do not provide CEUs, but you can download this certificate and go to an accredited association and request those CEUs there. Again, we are recording today. And lastly, we always like to know how we did. So at the end of the session, if you could let us know how we did, we'd greatly appreciate it. So I'm going to go ahead and pass things over to Susan, who is going to get things started and tell you about today.
Thank you so much. I am Susan Kashazta. I'm the Senior Outpatient Consultant for Solventum. We do have a packed agenda today. We'll start with the key policy updates surrounding the various quality reporting programs, OPPS and ASC Final Rule changes, including deletions from the inpatient-only list and updates to ASC covered procedure list. Khadijah Hasan will then provide key updates to the physician fee schedule, and Brad Howard will cover the 2026 CPT updates, including evaluation and management, surgery and radiology sections. And then we will wrap up with code changes and additions surrounding medicine. Starting with the hospital outpatient quality reporting. The Hospital Outpatient Quality Reporting Program is a pay-for-reporting initiative by CMS. It requires hospital outpatient departments to submit data on specific quality measures. If the hospitals fail to report, they do face a 2% reduction in their annual OPPS payment update. CMS also publishes this data on Care Compare, which allows patients and caregivers to review the hospital performance and make the informed decisions. CMS is introducing a new electronic clinical quality measure called Emergency Care Access and Timeliness. Hospitals will begin voluntary reporting in the calendar year 2027 reporting period, and mandatory reporting will start in calendar year 2028 for the 2030 payment determination. This measure is designed to replace older emergency department timeliness metrics and improve the accuracy and relevance of quality reporting. CMS is removing several measures to reduce reporting burden and streamline the OQR program. COVID-19 vaccine coverage removal is being finalized beginning calendar year 2024, hospital commitment to health equity and screening for SDOH removed in calendar year 2025. Emergency department timeliness measures, median ED departure time left without being seen, removed by calendar year 2028 and replaced with a new eCQM. For measure extension, CMS is extending voluntary reporting for the excessive radiation dose, inadequate image quality eCQM starting calendar year 2027 to give hospitals more implementation time. The extension helps improve imaging safety and supports CMS evaluation of national adoption. The extraordinary circumstances exception policy now explicitly allows extensions with a shorter 60-day submission window. The REHQR program key updates. The Rural Emergency Hospital Quality Reporting Program requires REHs to report specific quality measures to CMS. The key updates include the introduction of the Emergency Care Access and Timeliness ECQM as an optional measure starting in calendar year 2027, which can be reported instead of the median ED arrival to departure time measure. CMS is also removing several measures beginning in calendar year 2025, including the hospital commitment to health equity and 2 measures related to social drivers of health. Finally, CMS updated the extraordinary circumstances exception policy to include extensions as a relief option and shorten the submission window from 90 to 60 days after a qualifying event. These changes aim to simplify reporting and provide flexibility for rural hospitals. The Ambulatory Surgical Center Quality Reporting Program. This program is a pay-for-reporting initiative requiring ASCs to submit quality data to CMS. Failure to report results in a 2% reduction in the annual ASC fee schedule update. CMS also publishes this data on Care Compare for transparency. For the calendar year 2026 updates, CMS did not finalize adoption of the information transfer pro-PM measure or the requirement for ASCs to use the hospital quality reporting system for pro-PM submissions. Several measures are being removed, including COVID-19 vaccination coverage starting in calendar year 2024, and health equity and social drivers of health measures starting in calendar year 2025. And then lastly, CMS updated the extraordinary circumstances exception policy to include extensions and shorten the submission window from 90 to 60 days after a qualifying event. These changes aim to simplify reporting and reduce administrative burden. The requests for information for the hospital outpatient, REH, and ASC quality reporting programs. CMS is looking to expand beyond traditional clinical measures and incorporate concepts of overall well-being and healthy lifestyle practices. This includes measures for emotional health, social connections, and life satisfaction, as well as frameworks that encourage healthy eating, exercise, and physical activity. The goal is to align with current administrative priorities and improve meaningful measurement of patient health. CMS has received feedback and it will use it to guide future updates to the hospital outpatient, rural emergency hospital, and the ambulatory surgical center quality reporting programs. The updates to overall hospital quality star rating. CMS continues to use the existing framework, which is built around 5 major measure groups: safety of care, mortality, readmission, patient experience, timely and effective care. The rating methodology still incorporates as annual refresh score standardization and uses K-means clustering to assign hospitals to their final star ratings. CMS is placing greater emphasis on patient safety with the star ratings. This involves a 2-stage update that retains current methodology and adds new final step to increase safety of care weight. Stage 1 is effective calendar year 2026, introduces a 4-star cap for hospitals in the lowest quartile of safety care safety of care performance if they were initially rated 5 stars through K-means clustering. This ensures that hospitals with poor safety conditions cannot achieve the highest rating. Stage 2, beginning calendar year 2027, replaces Stage 1 and applies a blanket 1-star reduction for hospitals in the lowest quartile of safety of care performance, affecting those initially rated 2 to 5 stars, while maintaining a minimum rating of a 1-star. These changes aim to strengthen accountability for patient safety and ensure that star ratings better reflect hospitals' performance in preventing harm. Stage 1 and Stage 2 updates only apply to hospitals with at least 3 safety of care measures. This ensures the reduction is based on reliable data. Hospitals with 1 or 2 safety of care measures will still receive a safety of care score, but they are exempt from additional reductions because the data is limited. Hospitals with 0 safety of care measures do not have this group factored into their overall rating. Their patient safety performance cannot be measured reliably, so no penalty or benefit applies. The primary goal is to address the concern that hospitals with poor safety performance could still receive a 5-star rating. CMS wants to emphasize patient safety across all performance levels, not just among top-rated hospitals. These changes reflect CMS's commitment to improving healthcare outcomes and advancing patient safety standards nationwide. The key updates for the calendar year 2026 OPPS ASC Final Rule. CMS issues this rule annually to update Medicare payment policies for hospital, outpatient, and ASC services, as required by law. CMS finalized a 2.6% increase for both OPPS and ASC payment rates, applicable only to facilities meeting quality reporting requirements. These updates impact approximately 4,000 hospitals and 6,000 ASCs nationwide, making it a significant policy change for outpatient care. Derived from a 3.3% market basket increase, reduced by a 0.7% productivity adjustment, resulting in the net 2.6% update. The rule ensures payment systems remain aligned with current market condition and supports quality reporting requirements. CMS is phasing out the inpatient-only list over 3 years, starting calendar year 2026. 285 musculoskeletal procedures will be removed first, allowing these services to be paid in the outpatient setting when clinically appropriate. The goal is to allow more choices for beneficiaries, potential for lower out-of-pocket costs, and greater flexibility for physicians in determining the most appropriate site of care. This reflects advances in medical practice, shorter recovery times, and improved safety, making outpatient care feasible for more procedures. The 2 midnight rule exemptions, procedures removed from the inpatient-only list remain exempt from certain medical review activities under the 2 midnight policy. This exemption continues for calendar year 2026 and beyond until CMS determines these procedures are more commonly performed outpatient for Medicare patients. And included here is a link for reference. Here we have just a handful of the 285 codes that were removed from the musculoskeletal category. 20805, reimplantation of forearm, replantation, excuse me. 21268, orbital repositioning, periorbital osteotomies. 21247, reconstruction of mandibular condyle with bone and cartilage autografts. 21344, open treatment of complicated frontal sinus fracture. 21615, excision, first and or cervical rib. 22533, arthrodesis, lateral extracavitary technique, including minimal discectomy to prepare inner space, lumbar. 22819, kyphectomy, circumferential exposure of spine and resection of vertebral segment, 3 or more segments. And then 22846, 4 to 7 vertebral segments. 27132, conversion of previous hip surgery to total hip arthroplasty with or without autograft or allograft. 27303, incision deep with opening of bone cortex, femur or knee. And 27880, amputation leg through tibia and fibula. And then approximately 50 codes from other categories such as anesthesia, digestive, and radiology were removed as well. The link included at the bottom includes the calendar year 2026 inpatient only list, and that is found under Addendum E. CMS revised the ASC covered procedures list criteria for calendar year 2026 to increase flexibility while maintaining patient safety. The key changes here are modified general standard criteria, removed 5 exclusion criteria and moved them to a new section as non-binding physician considerations, emphasizing clinical judgment. The impact is the addition of 289 procedures due to criteria changes and added 271 codes from inpatient-only list removals. The goal is that these changes allow physicians to exercise medical judgment and give patients more options for surgical care settings while still prioritizing safety. CMS finalized a 0.5% OPPS conversion factor reduction for calendar year 2026 for non-drug items and services. Hospitals enrolling after January 1st, 2028 are exempt. The reduction is part of the 340B final remedy to repay an estimated $7.8 billion by calendar year 2041. The goal is to gradually restore hospital financial position without sudden payment cuts. CMS did not finalize a proposed 2% reduction for 2026 based on stakeholder feedback. A larger reduction of approximately 2% or more is expected to begin in calendar year 2027. Historically, since calendar year 2014, CMS packaged skin substitute products with their application procedures under OPPS and categorized them as high cost or low cost. In the non-facility setting, these products were paid under ASP plus 6%. For the calendar year 2026, CMS finalized major changes. Skin substitutes will be unpackaged from application services. The new APCs will be based on product characteristics, not the price. Payment categories will align with FDA regulatory status 361 HCT/P, PMA, and the 510K. For 2026, CMS will use a single payment rate for all 3 categories to avoid underestimating resources. Future years will differentiate these rates. These changes apply to both hospital outpatient departments and physician offices for consistency. CMS aims to recognize clinical and resource differences, encourage innovation, and generate savings for the Medicare Trust Fund. CMS finalized a policy to strengthen compliance with anti-discrimination laws in residency program accreditation. Accrediting organizations cannot use criteria that promote or encourage discrimination based on race, color, national origin, sex, age, disability, or religion. This includes intentional proxies for these characteristics. Prohibited uses include employment decisions, program participation, resource allocation, other activities, opportunities, or benefits. The goal is to ensure fairness, equity, and integrity in the accreditation process. The access to non-opioid treatments for pain relief. CMS is continuing its policy to provide temporary additional payments for non-opioid pain relief treatments in hospital outpatient and ASC settings. This policy runs from January 1st, 2025 through December 31st, 2027. Starting in calendar year 2026, 5 drugs and 11 devices will qualify and be paid separately in both settings. The goal is to reduce opioid use and prevent opioid use disorder, supporting safer pain management options. CMS is considering a more frequent approval process for new qualifying products and encourages public input. Updates to this section 4135 qualifying products list will occur as soon as feasibly possible, operationally feasible. The add-on payment for technetium 99M. CMS finalized a $10 add-on payment per dose of technetium 99 derived from domestically produced MO99 starting January 1st, 2026. This policy incentivizes domestic production of MO99 to strengthen supply chain and reduce reliance on foreign sources. To qualify for the add-on payment, at least 50% of MO99 and the technetium 99 generator must be domestically produced. This applies to TC99M derived from non-HEU MO99. CMS established a new HCPCS code, C9176, to simplify billing and reimbursement. The add-on payment reflects the higher cost of domestically produced technetium 99 and ensures equitable payments for providers. The goal here is to improve access to domestically produced radiopharmaceuticals while minimizing administrative burden. The intensive outpatient program. CMS is maintaining the current rate structure. That means we see 2 APC groups for every provider type. 1 for 3 days where 3 services are delivered and 1 for days where 4 or more services. This creates predictability and keeps the payment model aligned with service intensity. For hospital-based programs, CMS is using calendar year 2024 claims data combined with cost report information from the past 3 fiscal years. They are continuing to rely on the broader OPPS data set, which includes both IOP PHP days and the non-IOP PHP days. This approach helps CMS capture a fuller picture of resource use and ensures rates better reflect the actual variation in service intensity across facilities. For community mental health centers, CMS finalized a new methodology. CMHC costs will be set at 40% of hospital-based IOP. There are a couple of reasons for this change. One is to fix a long-standing cost inversion problem, where surprisingly the 3 service days were showing higher cost than the 4+ service days. Another reason is to stabilize CMHC rates by relying on larger data set, which results in more reliable calculations. And then finally, the 40% ratio preserves the structural differences between CMHCs and hospitals, reflecting real-world differences in staffing, infrastructure, and overhead. Why does this matter? These updates ensure patients with mental health or substance use disorders can receive intensive treatment without full hospitalization. Payment stability, maintaining a clear rate structure and adjusting CMHC methodology helps stabilize reimbursement and avoid cost distortions. And then fairness across providers, aligning CMHC rates with hospital benchmarks ensure equity while accounting for structural differences. Using OPPS claims and cost reports improves accuracy and reflects real-world service intensity. And then the policy impacts, they support continuity of care and encourages providers to offer IOP services in multiple settings, including rural and community clinics. The partial hospitalization program. PHP is an intensive outpatient alternative to psychiatric hospitalization. It requires at least 20 hours of services per week and is paid on a per diem basis under OPPS. The calendar year 2026 rule updates how these rates are calculated for hospital outpatient departments and community mental health centers. CMS is maintaining the existing structure. 2 APCs per provider type, 1 for days with 3 services and 1 for days with 4 or more services. This ensures the consistency and clarity for the providers. For hospitals, CMS uses calendar year 2024 claims and cost reports from 3 years prior. The OPPS dataset includes both PHP and non-PHP days to capture accurate service intensity. For CMHCs, CMS will calculate costs as 40% of hospital-based PHP costs. This change fixes a previous cost inversion and stabilizes rates by using a larger data set while accounting for structural differences. These updates preserve differences between CMHCs and hospitals. They ensure fair and predictable rates and improve accuracy by leveraging broader data. Overall, this approach supports stability and equity in PHP reimbursement. I will now turn it over to Khadijah for the PFS portion of the for the presentation, excuse me.
Thank you, Susan. So now we will go over the 2026 physician fee schedule updates. CMS historically relied on AMA RUC surveys, which are subjective and prone to bias. Many services have inflated time assumptions, leading to distorted payment values. The new efficiency adjustment applies broadly except for time-based codes. This change aligns valuations with actual practice efficiency gains over time. CMS will prioritize empiric data and continue refining valuation methods. These updates respond to concerns raised by MedPAC, GAO, and researchers about payment inequities. CMS revived AMA's updated PPI and CPI survey data, but found significant limitations, so it will not be used for calendar year 2026 rate setting. Instead, CMS is modernizing practice expense methodology to better reflect current practice patterns. Office-based practitioners will see recognition of higher indirect costs compared to facility settings. CMS will leverage routinely updated hospital data for certain technical services, starting with radiation treatment and remote monitoring. These changes aim to improve transparency, accuracy, and reduce reliance on outdated survey data. CMS is also simplifying telehealth services in addition by removing provision versus permanent distinctions. Frequency limits for certain inpatient, nursing facility, and critical care telehealth visits are permanently removed. Virtual direct supervision is now allowed for specific services, improving flexibility for practitioners. Teaching physicians can maintain a virtual presence permanently for services delivered virtually, such as responding to public comments. CMS is introducing optional add-on G codes for advanced primary care management services. These codes support behavioral health integration in the collaborative care model, making it easier for practitioners to provide comprehensive care. For digital mental health treatment, they are expanding payment policies for digital mental health devices, including those used for ADHD treatment. They are also considering future policies for broader digital therapy tools to complement mental health treatment plans. These initiatives aim to improve access, integration, and outcomes for patients with chronic and behavioral health conditions. CMS is adopting optional add-on codes under PFS for APCM to facilitate billing for behavioral health integration and psychiatric collaborative care model services. Starting January 1st of 2026, RHCs and FQHCs must report individual codes for COCM and CTBS remote evaluation services. Care management services under PFS will be treated as care coordination services for separate payment in RHCs and FQHCs, improving alignment and transparency. CMS is finalizing a permanent definition allowing supervision through real-time audio and visual telecommunication, excluding audio only. And for telehealth billing, non-behavioral health visits furnished via telecommunication can be billed using HCPCS code G2025, including audio-only services through December 31st of 2026. And lastly, CMS is finalizing a claims-based methodology to exclude 340B units from Part D rebate calculations starting January 1st of 2026. 340B repository, CMS will create a repository for voluntary submissions for Part D claims data for covered entities. This will support usability testing and improve rebate program accuracy. And now I will pass it over to Brad for the 2026 CPT updates.
Thank you so much, Khadijah. So let's take a look at the updates to the CPT code set for 2026. We've got a summary of changes shown here, 288 code additions, 46 revisions, and 84 deletions. This sums up to 418 distinct changes. And that means we still have a lot of slides here and a little bit of time to get through them. So I do want to remind you about the Q&A feature if I happen to go too quickly through an area of interest to you. So let's start with evaluation and management. And here we can see the changes of the code descriptors for remote physiologic monitoring. 99453 has been revised. The descriptor still remains relatively unchanged. The only exception is the semicolon moving to distinguish the parent code termination point with the addition of new code 99445. 99445 is available for reporting the supply of device and daily recordings or program transmissions for 2 to 15 days in a 30-day period. And you can see the parenthetical changes to the parent code there, reducing the minimum monitoring period from 16 days to 2 days. So this is a pretty significant change for RPM services. In addition, 99454 in the same code family has also been revised with the addition of that code 99354 for 2 to 15 days of reporting. 99454 has been revised to describe a 16 to 30-day period. There have also been multiple parenthetical additions to this code due to new CPT codes and to distinguish remote physiologic monitoring from remote therapeutic monitoring.
Brad, there is a question.
Yeah.
They want to know, is there a slide to reference the pass-through information that you're presenting?
I'm not sure if we do have that available, but we can make that available to you after the call. Will you identify the commenter, and we'll make sure to follow up with that.
Okay.
Yeah, this section is really just highlighting the changes and doesn't include any of that pass-through information, but let's work on that on the back end, and we'll try and get you something after the call. So previously, this subsection, the RPM Treatment Management Services subsection, contained two codes, the 99457, which was the parent, and 99458, which was the child. For the 2026 code set, new parent code 99470 has been added, and decreasing the time threshold necessary to report RPM services to 10 minutes. 99457 has been revised to become a child code, although it retains that same 20-minute threshold as in previous years. Nine 99458 remains a child code, now under parent code, now under that new parent code 99470. This is still an add-on code. It should only be used with 99457. But we do have new parentheticals directing you not to report 99457 or 458 with the new code 99470. And due to the addition of 99470, there's been a new table added to the manual to specify the time in a calendar month for RPM services and how they should be reported. So if you're using these services, make sure to reference the new time thresholds in the table. All right, moving on to the surgery section of the code book. In the musculoskeletal chapter, we do have some code descriptor revisions made to codes for sacroiliac joint arthrodesis, along with new parenthetical guidelines instructing that 27278 cannot be reported in conjunction with 27279 when they involve the same SI joint, so the same laterality. The previous code descriptors for 278 and 279 separated these procedures based on whether the fusion involved the use of an internal fixation device or the percutaneous placement of an intra-articular stabilization device. And so the term transfixation was replaced with intra-articular and trans-articular for these two codes. And these terms to clarify whether the fixation device is placed within the joint or placed across the joint. The two codes are also differentiated by whether or not the device pierces the cortices of the ilium and the sacrum. Uh, 27458 is a new code. This is out of numerical sequence. It describes a new externally controlled intramedullary lengthening device used for treating limb lengthening inequalities due to infections, trauma, or congenital conditions. And osteoplasty code 27468 has been deleted. This was the code that if they did a shortening on one side and a lengthening on the other, it has been deleted both due to low utilization and variability in how the procedures are provided. Under the leg and ankle joint, new code 27713 describes a unilateral tibial osteotomy with an insertion of an externally controlled intramedullary lengthening device. It identifies the procedure of cutting a bone to correct deformities, realigning the bone structure, or lengthening the bone. And this can be used for indications such as arthritis, inconsistencies with the lengthening of the long bones, or malignancies. A lot to go through in the cardiovascular chapter, and we'll start here in the surgery section. These are endovascular repairs of the aorta via endograft. 33880 includes the covering of the left subclavian artery by the endograft, while 33881 does not involve coverage of that vessel. So documentation of where exactly that endograft, the proximal portion of it, is placed is going to be important in differentiating between these two codes. This part still remains unchanged, but both codes still describe the endograft placement to the level of the celiac artery. And the revisions here involve inclusion of the pre-procedural work and sizing of the device selection, non-selective catheterization, and the associated radiological supervision and interpretation in the code descriptors. So this is the big change here to this set of codes. We can see the deleted parentheticals previously directing you to report 75957 separately. And you can also see that 33881 includes the initial endoprosthesis and any extensions if required. And so that's a big change to this code family too. And resulted in new code 33882. It's essentially the same procedure as described by 33880, but it states the endograft used has a fenestration for a left subclavian artery stent graft. And 35602 is a new code, a bypass graft with other than vein, carotid, contralateral carotid. It describes the distinct work of establishing cross-carotid revascularization when a native vein is not used. And this code includes exposure, tunneling, graft placement, and anastomosis, and closely resembles the deleted code 33891, which we'll see on the next slide. This is actually a child code now under 35601, but we've included the parent code prefix for you here. 33886 has also been revised with additional language added to describe the level of aorta involved. This remains a code for a delayed procedure performed after a previous thoracic endovascular aortic repair. But it also now includes those same additions, the sizing and device selection, all non-selective catheterization, all imaging guidance and interpretation needed to complete the extension. And so this would be used with 33880 if done at a separate session. A couple of deletions to mention, 33889 and 891 are no longer active codes to report. There are 46 new lower extremity revascularization codes and 16 deleted codes. The deleted codes shown here with strike throughs. One of the major changes in this section, and one of the reasons we have so many new codes in this section, is the addition of the language to distinguish the degree of stenosis, and documentation will need to clearly describe the percentage of stenosis to support accurate coding. And so this is one concept that must be known by the providers and the coding staff, is that when we're talking about these procedures, if we see the term a straightforward, that equals a stenosis, meaning that there is some blood flow that crosses the lesion. Complex is a completely occluded vessel. There is no blood flow. So up to 99.9% stenosed would be considered straightforward. This differentiation in the degree of the stenosis is what led to all of these new codes. Historically, there hasn't been this difference in coding for these procedures, whether they were partially stenosed or fully occluded. And we see this, we'll see this distinction in the code descriptors as we review them. Additionally, the new codes in this section are now comprehensive, bundling all of the following when performed. the access, the catheterization, the intervention, all associated imaging, embolic protection if used, the arteriotomy closures. Diagnostic angiography does remain billable if it is truly diagnostic and the decision to treat was based on the findings. So we want to see that documentation from the surgeon in the operative note. We would want to see as well that the separate angiography should identify that there was no prior diagnostic study available, or there was a change in the patient's condition since the previous study, or inadequate visualization, or a clinical change during the procedure, something like that, to show the medical necessity of diagnostic angiography. So we can start here looking at this first new code pair, 37254 and 37255. The language in these code descriptors changed quite a bit from 2025, and we really need to know three things when assigning these codes. We need to know the vascular territory, and we do have some changes to the vascular territory as well. The type of intervention, was this an angioplasty? Was it a stent placement? Was it an atherectomy? And whether the lesion is straightforward or complex. I have taken the liberty, the bold text in these code descriptors is mine. I just wanted to highlight those three areas to differentiate the codes. And as we can see here, we're looking at codes for the iliac vascular territory. This includes the internal and external iliac arteries. These two codes are for angioplasty of a straightforward lesion, 37254 representing the initial artery treated in this territory, and 37255 is an add-on code for each additional straightforward lesion. And one thing that may trip you up with these procedures is when these procedures are performed bilaterally. Coding instructions in the parentheticals following the descriptors direct us to use modifier 50 for the initial vessel, but to report 2 units rather than modifier 50 for each additional vessel. And this remains the case for the rest of the code pairs that we're looking at in this section. And here we have 37256 and 37257, still in the iliac vascular territory. We're still performing angioplasty, but these are for complex lesions. 37256 for the initial complex lesion treated with angioplasty, and 37257 for each additional lesion. Continuing in the iliac vascular territory, we have 37258 and 37259. We're still in the same territory, but now we're performing a stent placement, which does include any transluminal angioplasty when performed. So the pre or post angioplasty for stent placement is bundled into these services. So iliac vascular territory, stent placement, straightforward lesion, 37258, each additional vessel with a straightforward lesion, 37259. And a stent placement, including angioplasty, iliac vascular territory. These are complex lesions, 37260 for the initial, and 37261 for each additional vessel treated that contains a complex lesion. And 37262. This is a new code for intravascular lithotripsies that are performed in the iliac vascular territory. This includes any imaging guidance and RSNI to perform the lithotripsy. And you can use these with the angioplasties or the stent placements, the intervention codes as well, if it's performed in the iliac vascular territory. So those are all the codes. We've got angioplasty and stent placement as our only interventional options in the iliac vascular territory, but we're going to see some additions here in the femoral and popliteal vascular territory. We've got the same hierarchy structure for the interventions. This territory, the FIMPOP territory, includes the common femoral, the profunda femoris, the superficial femoral, and the popliteal arteries. And so same hierarchy. We have the two codes for angioplasty of straightforward lesions, the initial vessel represented with 37263, and additional vessels represented with add-on code 37264. Still looking at angioplasty, still in the FIMPOP territory, but these are for complex lesions, 37265 for the initial vessel and 37266 for each additional vessel. 37267 and 268 represent stent placements, straightforward lesions, and include any associated angioplasty.
Brad, can I stop you for 2 questions?
Yeah, thank you.
It says, when it says for bilateral procedure, report the code twice, should we report on 2 lines with left and right?
No, and I think so let me pause just real quick for maybe some expansion on this topic. It should be reported, I think, with 2 units. The issue here is that these add-on codes for the additional vessels do not necessarily have to be reported only with the code that precedes it. So here we're looking at stent placement in the FIMPOP territory for complex lesions. However, if we did a atherectomy in the FIMPOP territory, that would be counted as the initial, and then we could use add-on code 37270 for a complex lesion in the same territory that was only treated with the stent placement. So we can mix and match with these. You would always choose the highest hierarchy. It goes angioplasty, then stent placement, then atherectomy, and then atherectomy with stent placement for the hierarchy. We'd always use the highest one for that initial vessel, and then you can use the add-on codes for each additional vessel. So I think and these are new. I haven't seen these or audited these in real life yet, as the codes are extremely new. But my guidance here would be to report. It says report 37270 twice, so they may want it on different line items. Let me follow up after the call and see if we can get some clarification on whether or not we should be billing them on separate line items with laterality modifiers, or if it's okay and appropriate to report them with 2 units in these cases. That's a great question. Thank you.
And then there's one more for this section. Do we need I-70.92 for leg complex procedures?
As far as supporting the medical necessity, I don't know if, I think, let's see, hang on a second, let me look at my codes. I-79-2?
Yes.
Yeah, the only thing I don't love about having to have that is, well, we may need that to support it. What goes beyond that is the accurate documentation by the provider for selection of the code. So I have seen historically sometimes they will say a 99% occluded stenosis, right? Which with these new definitions does not mean an occluded area, or a 99% occlusion. That would be coded as a straightforward, and it should also be corresponding to the particular ICD-10 code for that. I don't know if I-70.92 is the only one, but it certainly is an appropriate one for the complex lesions. I'd have to double check to make sure to get you an exhaustive list, but that one absolutely should represent and support interventions designated by a complex lesion description. So we'll keep track of all of these, and I'll follow up with some emails with some additional information, but that one absolutely should, and I don't know if it is the only one that will, if that helps. Continuing on to the, still in the femoral and popliteal territory, here we're looking at transluminal atherectomy, straightforward lesion, 37271, each additional vessel in that territory with a straightforward lesion is 37272. Now, as you can expect, we're following the same kind of hierarchy here. Atherectomy for complex lesions, 37273 and 274. And stent placement here with atherectomy. So if both of these interventions are performed in the same session on the same vessel, we'd use 37275 for the straightforward lesion, 37276 for each additional, and 37277 for complex lesions, with 37278 being the add-on code in this section. Like we had for the iliac vascular territory, we also have a lithotripsy code, a new lithotripsy code in the FemPop territory, and this can be used with any of the interventional codes that we just reviewed. All right. In the tibial and perineal vascular territory, same structure, so I'm going to move through these fairly quickly in the for respective time here, 37280 and 81 for straightforward angioplasties in this territory. And again, this territory includes the anterior tibial, the posterior tibial, and the perineal arteries. 37282 and 83 for complex lesions. Stent placements on straightforward lesions in this territory, 37284 and 285. Complex lesions, 286, 287. Atherectomy, and again, the atherectomy and stent codes include any transluminal angioplasty for the same vessel, so don't report both of those codes together for the same vessel. 37288 and 89 for straightforward lesions, 90 and 91 for complex lesions. And stent placement with atherectomy, 92 and 93 for straightforward, 94 and 95 for complex. And this is the new vascular territory I mentioned earlier. These are the inframalleolar vascular territory. So these are the super tiny arteries in the feet. It includes the dorsalis pedis and the plantar arteries. We're currently only seeing angioplasties performed in this territory, so we only have 4 new codes in this section, 37296 and 97 for straightforward lesions treated with angioplasty, and 37298 and 99 for complex lesions in this territory corrected with angioplasty. Let's continue with the cardiovascular updates here, but we're in the medicine chapter of the code book. We're skipping around, but we're keeping the specialty consistent at least. Percutaneous coronary intervention cardiology CPT codes 92920, 92924, 928, 933, 937, 941, and 943. These were all revised to reflect the elimination of separate add-on codes for additional branch vessels. Descriptor and guideline updates ensure that a single primary code describes a complete coronary intervention in one vessel or territory. And the new definitions accommodate the complexity captured by the 2 new PCI codes above. In practice, this means The main coronary angioplasty, atherectomy, stenting, etc., now include typical additional branch work instead of requiring separate add-on codes. So here we have the first code in this family, 92920, where we can see the descriptor now includes angioplasty for coronary artery and or its branches. And the add-on code we had previously used for additional angioplasty in the branches has been deleted. Same type of change for the code representing atherectomy, 92924, with 92925 being deleted. And the same concept here with 92928, describing PCI stent placement. There is a key difference here with specificity added that it is to be used for a single lesion being treated. And so we do have the option, if there are multiple lesions, to report this twice. Add-on code for additional branches has been deleted. And 92930, this essentially replaces that, but is specific to the number of lesions and stents used. And so the added guidelines preceding this code family, they contain a lot of great information about coding for different scenarios. We don't have the bandwidth to get to it now, but if you are coding for cardiovascular PCI, make sure to review the new guidelines preceding this chapter. It also includes great scenarios, such as when a lesion extends from a major coronary artery into a branch. So you'll have a lot of nuanced scenarios identified in those guidelines. Again, we're talking about the same thing with 92933. It's revised to include coronary artery branches, and the add-on code has been deleted. And again, here for 92937, for CABG revascularization, with 92938 being deleted. 92941 represents revascularization during acute MI, and you can see the language changes that support revasc via any combination of stent, atherectomy, and angioplasty, and also the inclusion of an aspiration thrombectomy being part of this service when performed. And so I believe this is the only code that contains all revascularization via any method, and specific when the patient is acutely infarcting. And the last code changes in this section on this slide, showing 92943. This describes revascularization of a chronic total occlusion of a single coronary artery, as well as any subtended branches of a bypass graft. This has also been revised to indicate an antegrade approach. And we do have new code 99245 representing this work when performed via combined antegrade and retrograde approach from two axes. And so this wraps up the cardiovascular changes. In the digestive system, stomach 43889 has been added to report endoscopic sleeve gastroplasty for gastric restriction. And also added for the liver is code 47384, which describes percutaneous liver tumor ablation for one or more lesions. And this code does include the required imaging guidance to accomplish the procedure. Category 3 code 0619T has been deleted. We haven't included all of the Category 3 additions and deletions here, but we do include them when they have a Category 1 code that is taken over. And we have the case here. 52443 has been established. This new code has been established to report cystourethropy with initial transurethral anterior prostate commissurotomy. This is for the treatment of benign prostatic obstruction. And this procedure combines two balloon steps. In the procedure, first, an anterior prostate commissurotomy is performed to open the prostatic urethra. using a non-drug coated balloon. And then the second step is that a drug-coated balloon is inserted to deliver the therapeutic agent into the prostate. So we'd want to see documentation of both of those balloonings. Category 3 code 0421 key has been deleted and new code 52597 has been established. This describes a transurethral robotic assisted water jet resection of the prostate, again, treating benign prostatic obstruction. 55705, this is a revised code, and 55707 through 715 are the new codes in this section. The codes have been added to the code set. They really reflect new technologies used for prostate biopsies and are differentiated by the approach type and the imaging modality. So 55705 is used to report any type of non-image guided biopsy of the prostate. 707 is to report transrectal prostate biopsy via ultrasound. And 708 is for transrectal prostate sextant biopsies performed using both ultrasound and MRI fusion guidance. 5709 and 710 are to report transperineal prostate biopsies. 709 is obtained using only ultrasound imaging, and 710 is for that, again, that prostate sextant biopsy with both ultrasound and MRI. (711) is transrectal MRI ultrasound fusion only prostate biopsy of a single targeted lesion. So this differentiates it from the sextant biopsy. And 712 is for MRI and ultrasound fusion guidance for targeted lesions. 55713 is used for in-bore CT or MRI-guided prostate biopsy of sextants with biopsy of an additional targeted lesion. So this code identifies the use of CT or MR to not only select random tissue from each predetermined sextant, but to also harvest an initial additional lesion of interest outside of the sextant biopsies. And 55714 is used to report the CT or MR guidance prostate biopsy of targeted lesions only. 55715 is reported for any procedure where an additional lesion is performed in bore or for additional MRI ultrasound fusion targets. And also in the parenthetical there, it identifies the service may be performed in conjunction with any of the additional in-bore or additional MR fusion targets. With the deletion of the term peritoneoscopy throughout the code set, the guidelines preceding code 55866 have been revised to reflect this change. 55866 has been converted to a parent code with the addition of a semicolon to accommodate the two new child codes, 55868 and 869. These codes have been added to report laparoscopic radical removal of the prostate gland with limited for 55868 and bilateral 55869 pelvic lymphadenectomy. And 55877 has been established to report percutaneous irreversible electrocorporation of ablation of the tumors of the prostate. And I think that wraps up the codes for the male genital. So diving into the nervous system, section under skull, meninges, and brain, it was determined the code pairs 61624 with 75894 or 898 were reported at least 75% of the time based on Medicare claims data, and therefore codes 61624 and 61626 have been revised to include all of the radiological work to to complete the procedures. The descriptors have been revised, as well as any cross-references and parenthetical notes, and the introductory guidelines have been added. Parenthetical notes now instructing users, or the parenthetical notes that were instructing users to report the radiology codes with these codes have been deleted. So 61624 and 61626 now include the imaging as well. There is a new subsection. The heading is percutaneous decompression of neural elements. This has been added. We have a deletion of a category 3 code, 0275. That was one of the oldest category 3 codes. It has been deleted. Guidelines have been revised to include codes 62330, 62331, and 0274T, with several parenthetical notes being added. Code 62287 has been revised by removing the term procedure, and it has been relocated to the new subsection as a resequenced code preceding codes 62330 and 62331. So this new code 62330, it describes percutaneous bilateral decompression of the lumbar spine, involving partial removal of the ligamentum flavum and opening of the lamina to expose the site for the first interspace. The procedure includes imaging guidance, and you would report new add-on code 62331 for additional lumbar interspaces treated in the same session. And one thing to note here, these are sometimes performed unilaterally. Make sure you're appending 52 modifier if only one side is being worked on. Add-on code 63032, it should be reported in conjunction with 63030 when laminotomy is performed and an annular closure device is utilized. What's interesting here is that this is an add-on code that's only reportable with a child code. We've included the existing unrevised code family here for context. 0720T has been deleted and 64567 has been established. This is reporting for percutaneous electrical nerve field stimulation of cranial nerves without implantation of a neurostimulator device. And there weren't any code descriptor changes from the category 3 to the category 1. Here are the first 3 new codes previously represented with category 3 codes. 64654 describes the initial open implantation of a BAT system. It includes carotid sinus lead placement, tunneling, pulse generator placement, connection, and intraoperative interrogation and programming. 64655 reports a subsequent revision or replacement of the BAT system, but for the lead only. And 64656 reports revision or replacement of the system, pulse generator only. And here are the remaining 3 new codes, which reflect the removal of the BAT system or individual components. 64657 describes the removal of the entire system. 658 describes the removal of the lead only. And 659 describes removal of the pulse generator only. 64728 has been established to report decompression of the median nerve at the carpal tunnel, performed percutaneously. This is now a child code for parent 64722 and is specific to the median nerve. In the radiology section, we've got category 3 0042T. This was the oldest category 3 code previously. It has been deleted, and 70471 through 70473 have been established to report CTA and CT perfusion of the head, neck, and brain. 70471 specifies CTA of the head and neck and includes non-contrast imaging. And add-on code 70472 describes CT cerebral perfusion when it is performed in the same session as a head CT or a head and neck CTA. 70473 reports CT cerebral perfusion when it is performed without a concurrent head CT or head and neck CTA. And do not report 70473 with the CT CTA codes or with 3D post-processing codes. Category 3 codes, we had 0623T through 0626T, which were all deleted, and 75577 has been established to report quantification and characterization of coronary atherosclerotic plaque to assess the severity of coronary disease. And because this procedure is performed on data from a cardiac CTA, 75574 may be separately reportable for provision of a complete CTA service, as it describes here in the parenthetical notes. 77402, 407, and 412 have been revised. This is for daily external beam delivery. The revision really involves the 3 distinct levels. And the fact that image guidance is now included in the delivery codes. These codes have been revised to represent levels 1, 2, and 3, with guidance and motion management bundled as part of delivery. And there are new instructional notes preceding this code family with greater detail on the definitions and the difference in the levels. CPT 77401 and category 3 code 0394T have been deleted as of the 1st. All surface radiation therapy, including superficial and orthovoltage delivery, is now reported using codes 77436 through 439, which has resulted in a new subchapter in the radiology section for surface radiation therapy. These codes are differentiated by superficial or orthovoltage delivery, as well as the dosage, treatment planning, and use of ultrasound for image guidance for the placement of therapy fields. And note here that the second parenthetical for 77439 contains a duplication in the codes you should not report with this. We did report this to the AMA, and they issued a errata on this. The following codes, the strike-throughs at the bottom there in red, 77262 and 263, should be 77762 and 77763. And there's a errata published now highlighting that change. Going back to the medicine chapter, everything except the cardiovascular we already reviewed. 90382 has been established to report use of an immune globulin to provide immunization against contracting RSV. There have been some guidelines added and revised to include codes 90481 and 91323 and language to detail intended use for 90481. This language for this new add-on code directs users to existing add-on code 90461 for the administration of additional vaccine components for which COVID-19 is one of the components and for which counseling is provided, and to provide directions regarding intended usage of codes 90482 through 484. So you can see the revision here for 90481, and this is fairly important. The single dose has been removed there, and then you would only state the first or only component of each vaccine administered for 90481 0 moving forward, and each additional component administered using 90481. So they did add on a new add-on code and revised the parent code there. 90482 through 484 have been added to identify immunization counseling provided by a physician or other QHP when an immunization is not administered by the provider on the same date of service. These are great for instances in which the counseling is provided, but the patient, for whatever reason, refuses the administration. New code 91323 for a COVID vaccine with a different dosage, 10 micrograms per 0.2 milliliters. 90593 describes a recombinant vaccine for the prevention of the chikungunya virus. 90631 was established to report a non-specific avian influenza product that may be used for any H5 influenza protein. 90612 and 613 have been established to report vaccines that combine influenza virus and COVID-19 components within a single vaccine. And 90620 has been revised to remove the dose schedule language. This allows the code to be used for any meningococcal recombinant vaccine containing this combination of constituents. 12 new codes here. If any of you are specific to otorhino, let me know, but we're going to move through these fairly quickly. These are all new codes established to report hearing device services. The new table in the book lists the major categories of services, their associated codes and assigned times. It's in that the new evaluative and therapeutic services subsection of the special otorhinolaryngological services following the new codes. And so these time tiers really let you report the intensity of work with add-on units for longer visits, and verification services are separately reportable when performed. Yeah, due to the increased use of mechanical scalp cooling, this service now meets the Category 1 criteria. This is often something that's used with alopecia or concurrent with chemotherapy delivery. Category 3 codes 0662 and 0663T were deleted, and these three new codes 97007 through 009 have been established for reporting of this service. And these are pretty self-explanatory. If you're doing this work, you're probably already aware of these new codes coming out. In conclusion today, the key policies for the calendar year 2026 OPPS ASC payment system and final rule, inpatient only list. Make sure to check out that link that was included on one of the first slides that Susan reviewed for a complete list of the inpatient only, because there were quite a few deletions off the IPO list this year. The ASC covered surgical procedures, CMS prior authorizations, and the quality reporting program, as well as the available references, including the new code book and guidelines for the 2026 CPT code set. All right. Hey, look at that. I got through that like a champ and left some time for some questions if we've got any additional ones.
Yeah, absolutely. And again, this was a great presentation. We appreciate everybody's participation. Before I get into the questions, just quick couple reminders. The presentation slides are available in the resources. And the recording will be on our website in the next couple weeks. I know there was a couple people that had some issues while joining. So in the next couple weeks, we will have this recording on our website. All right, so I'm going to start at the beginning. there was a mention about getting a resource or grid for the different categories of remote monitoring. I know, Brad, you said that you'd be following up with folks after. But a question did come in about, do we need 170.92 for leg complex procedure? And I know that was much earlier in the session that this question came in.
No, that's fine, and I think we kind of addressed it during the conversation. I think that code is absolutely appropriate for that instance. I don't know, however, if it's the only code that's available. And then I saw that one that we may have just cleaned up again, but it looked like it came in a little bit later, describing the difference between the complex lesion and the straightforward lesion. And I know, I audit charts a lot, and I do a lot of interventional radiology and cardiology auditing. I know this is going to be a problem with the providers. That the difference between the complex and the straightforward, the complex must be documented at 100% occlusion. Anything less is going to be a straightforward lesion. And I know that some of the providers use the term, I'm struggling for an example here, but almost occluded or nearly occluded. Just because it says occluded, if it has that kind of caveat to it, you would not want to use the complex lesion code. There must be documentation that this was a completely occluded lesion in order to use the complex. Anything else, you default to the straightforward lesions. And I think, Lisa, we also did that last one that you have up there, number 8, on the bilateral procedure for the add-on codes. I'm interested too, because I've been working on this presentation, and I didn't even think to question whether it's more appropriate to report them on separate line items with laterality modifiers, or if it's better to report them with 2 units. The way that the instructional parentheticals are listed on the add-on codes to report it twice leads me to believe that it should be on separate line items. But we will double check and provide that feedback after the presentation.
Okay, fantastic. Well, that is all as far as our questions. Just a couple last things. If you are interested in learning more about our educational boot camps, I definitely encourage you to take a look at these. There's a link within the resources section. If you're interested in learning more about those, we go over topics like advanced CDI, quality, and CDI pediatrics. So you can see those sessions there and you can learn more. Again, that link is within our resources. And then if you are a customer, we do encourage you to join us June 14th through 17th. We will be back at the Grand America in Salt Lake City for our Solventum Client Experience Summit. There's also a link in our resources as well. Registration is coming mid-February, so we hope you can join us. And again, we appreciate our speakers today, a lot of great information. So when we end today's session, please feel free to complete the survey to let us know how we did. We do have a couple other webinars coming up. We just sent out a registration today, so we have another one in February and in March, so we hope you can join us then as well. So again, I thank you to our speakers, and we look forward to having you on our next quality webinar. Have a great day, everyone.